Let's start. Hi, everyone. I know Zoom is a little less interactive, and uh, I would appreciate if whoever can turn on the camera can turn on the camera so that we can see each other, and this feels more like an interactive session than just me having a one-sided talk. Um, so my name is Anjum Anwar. I am one of the assistant professors at University of Washington, and I kind of wear multiple hats here. I am patient safety and QI lead for our residents education, and I'm also labor and delivery anesthesia director for Northwest Hospital. I'm also heavily involved in education, especially simulation education is my area of interest. So I run our residents' OB anesthesia simulation courses as well. This is just a picture of Seattle. I just wanted to show everyone. Actually, GPT created this for me, so it's a little artificial. You can see our Space Needle here. So this is what the Seattle downtown looks like. This is our University of Washington. It's a really beautiful campus, and you can see there is Mount Rainier in the background. Again, this is an AI created image as well. So we can see everything in here. As far as my disclosures, I don't have any disclosure. Nobody pays me other than University of Washington, where I work. Um, so yeah, and all the content here is kind of like peer reviewed and taken from all the authentic sources. Just something to mention. So I just want to keep the learning objective very simple. I just want all of us to take this message from here that pregnancy is a new normal. And, understanding this new normal phase of human physiology is important because it can help us prevent overtesting and missing critical emergencies. So I do OB anesthesia day in and out. So, these physiological changes, they impact our daily life. And I'm sure you all have seen that too. Um, I'm not sure how many of you are heavily involved in OB anesthesia, but I think all these changes are gonna impactful for learning about this will be important for all the groups who take care of patients on labor and delivery. So as I'm an anesthesiologist, my most favorite systems are cardiology, cardiac physiology, pulmonology, and GI. So I'm just gonna stress more on those and then briefly touch some other as well. So I'll just start off with what kind of cardiovascular systemic changes occurs in a pregnant woman. So just to summarize, and then I will explain it a little bit more. In pregnancy, our cardiac output increases 30 to 50%. So, right, a significant number. But at the same time, our systemic vascular resistance, it goes down as well, and it is progesterone mediated. Progesterone kind of causes generalized vasodilation. And because of that, blood pressure initially drops up to 10 millimeter of mercury in pregnancy, but towards the term, it returns to baseline because of some other changes, and we'll talk about it. From a physical exam perspective, like I mentioned, the cardiac output increases. So 90% might have a systolic flow murmur, and that is very normal. And sometimes, you can hear an S3 gallop sound on auscultation as well, which is, normal as well. The only thing we should be careful about, and I just put it as a warning as well, any diastolic murmur that we hear during pregnancy, they are always pathological. So you have to be very careful. So this is just a graph showing that how the cardiac output increases in pregnancy. As we all know, that cardiac output is actually a combination of stroke volume and heart rate. So by the end of second trimester, there are both anatomic and hemodynamic changes that occur as pregnancy progresses. So the left ventricle becomes more hypertrophied as blood volume and cardiac output increases, leading to a slight increase in left ventricular mass. So you can see a displacement in PMI leftwards and slightly shifted axis on EKG as well. Cardiac output will be elevated 40 to 50% above pre-pregnancy, and this change 25% happens because of your stroke volume, and 25% is 15% is due to your heart rate. And then, as the patient presents in labor and labor progresses, cardiac output increases further due to uterine contractions. This because the uterine contraction cause increased venous return and increased sympathetic activity. And the most important period for us is immediately after delivery. So this is something that is, frequently kind of missed as well, because as soon as patient is delivered, we are all very happy that everything went fine. But immediately after delivery, cardiac output increases to the max even more because of autotransfusion once the placenta is delivered. So this is the time which is a very, very critical window for patients with pre-existing cardiac conditions, and they are at most risk during this time. And similarly, it happens, up to 2 weeks postpartum. So this autotransfusion keeps happening. So that's why it's important to, monitor patients, especially with cardiac pathology during this time. So another thing to mention is like in order to maintain normal blood pressure because of increased cardiac output, the systemic vascular resistance actually decreases during pregnancy. So like I mentioned earlier, overall we see a decrease in systolic and diastolic blood pressure up to 10 to 20% because of maternal vasodilation, which happens from progesterone level. And yeah, and towards the term, it kind of started to become normal to the physiological level. Again, at the same time, when the cardiac changes are happening in heart, there are hematological changes happening in our vascular system as well. We all know about the dilutional gap. There is a hypervolemia in pregnancy. The plasma volume increases up to 50%. But then RBC mass kind of lags behind and only increases 20 to 30%. So that contributes to the physiological anemia of pregnancy. So we all know the hematocrit drops, and we see this anemia in all of our pregnant patients. So overall blood volume is approximately 40 to 50% above the pre-pregnancy value towards the term. So this increased volume actually is very helpful, and this dilutional anemia has a critical importance because it helps with losing oxygen carrying capacity, and then it also helps with the large blood loss volumes that happens, normal physiological blood loss that happens after delivery or a C-section. um, so while we see that blood volume has gone up in pregnant patient, usually you don't see an increase in CVP or pulmonary capillary wedge pressure. We usually don't monitor, but if you are monitoring, you will see the pressures are kind of very similar to non-pregnant state. Okay, I tried to add a couple of questions. I'm not sure if you guys can unmute and, is anybody gonna volunteer to answer? So we have a patient who is 28 weeks pregnant, and her hemoglobin is 10.8, but MCV is normal. So what do we think is the most likely explanation? Anybody want to volunteer? No. Okay, so this is actually the same thing that we were talking about, physiological anemia of pregnancy. Plasma volume expansion, like we talked about, exceeds RBC mass, and this causes dilutional anemia. So this is the normal physiological anemia of pregnancy. Just another small clinical pearl. A pregnant patient at 18 weeks has blood pressure of 142/92. Which statement is most accurate? Do we think this is physiological due to pregnancy-related vasodilation? Is it gestational hypertension? Is this abnormal and suggests chronic hypertension? And this is a normal expectation in second trimester. So basically, hypertension before 20 weeks is not physiological, and it suggests chronic hypertension. Another important thing to talk about when we are talking about the cardiovascular changes in pregnant patients is aortocaval compression. It's called supine hypotension syndrome of pregnancy. So basically, what happens in pregnancy, the gravid uterus after 20 weeks is kind of growing really fast and growing into the pelvis, and this causes compression of IVC. So this compression of IVC actually leads to decreased venous return, decreased preload, and cardiac output, and then at the same time, because IVC and aorta are kind of next to each other, the gravid uterus is also pressing on the aorta, and this pressure on the aorta actually causes increased afterload, so which leads to decreased output, cardiac output as well, and impaired uterine blood flow. So therefore, a uterine blood flow not only decreases and leads to decreased cardiac output, but there is also direct compression of internal iliac arteries as well. So this can contribute significantly to maternal symptoms of hypotension, lightheadedness, dizziness, and decreased fetal heart tone. So these patients usually need a 15 to 30 degrees of left uterine displacement to avoid these symptoms. As an anesthesiologist, this is very important for us, especially after a neuraxial block, because after a neuraxial block, you have already taken away the sympathetic tone. And it is very important to be vigilant at this time that a pregnant patient is not laying supine. So I tell all my residents that if there is a baby in a tummy, the patient should never lie supine. So you should always try to have a 15 to 30 degree of left uterine displacement. And this is very helpful in relieving aortocaval compression. And it is preferred towards the left because aorta is more resistant to compression compared to the IVC. So that's why we talk about left uterine displacement. So here is just a small image showing how the supine position and gravid uterus is compressing the aorta and IVC. And then this how this vessel compression causes maternal impact, leading to decreased venous return to heart and hypotension. And as a result of this, you see decreased uterine blood flow, fetal hypoxia, fetal deceleration, and distress. So left lateral tilt, either patient can be in left position or, left lateral position, or you can wedge her to have a 15 to 30 degree tilt. Okay, just a clinical pearl again, since seems like I am going to ask the question and answer as well, so I'll do it. A term pregnant patient becomes hypotensive and nauseated while laying flat. What's the best immediate intervention? IV fluids, Trendelenburg position, left lateral positioning, and vasopressor. And like we just talked about aortocaval hypotension syndrome, this is supine hypotensive syndrome due to IVC compression and aortal compression. So we can do left lateral positioning right away. So any pregnant patient with a gravid uterus, first action mechanism of first action should be left lateral position in case of hypotension. Okay, so let's talk about some organs, how pregnancy affect our organs, and how it impacts us in our clinical practice. I just want to pause here and take a minute. If anybody has any questions so far from cardiac physiology, cardiovascular system, we can talk about it now. I'm happy to answer. I want all of us to stay awake as well. Are there any questions?
Yes, I have a question.
Sure.
Yes, my question is after doing your spinal anesthesia,
Mhm.
how long do you take to tilt the patient? Do you wait until the spinal peaks or just do it immediately, giving the spinal anesthesia after pushing the bupivacaine?
Yeah, really good question. So, as soon as you do your spinal and you are lying the patient, you should never lie the patient flat. So, you should lie her with a 15 to 20-degree tilt, and then you can keep her that way. But if you are worried about your block, kind of not increasing towards the left side, then you might provide a little bit of right tilt as well. And then treat more with vasopressors in that situation. But the ideal situation would be as soon as you're done with your spinal, you lie the patient with a 30-degree tilt. And that's what we do. Actually, all of our ORs, some of them have like an inbuilt tilt. So we do it unless, there is some other situation. Great question. Hmm. Do you guys do it? And then we kind of leave that wedge 15 to 30-degree tilt till we deliver the baby. Because then the gravid uterus is gone, and then the uterus is back to normal, and the aortocaval compression is kind of normalized. Okay, any other question? Okay, so let's get to our different organs. What happens when, a pregnant woman is going through a physiological changes? Like we just talked about how cardiac output increases throughout the pregnancy, most organ system also experience increased perfusion. I'm gonna talk about two of the organ system here, which are kind of important for us in pregnant patient. There is increase in renal system and uteroplacental unit. Uh, Renal blood flow actually increases by 60% at term compared to the pre-pregnancy state. And uterine blood flow, which is in a non-pregnant patient, 50 to 100 ml per minute, it increases tenfold by term due to dramatic increase in metabolic demands and low vascular resistance of uteroplacental unit. And then, a lot of collaterals that develop during pregnancy as well, they leads to increased perfusion of uterus. So very, very important from a clinical perspective to remember this, that a term uterus has a blood flow of close to a liter per minute. So, why this is important? It is very important for our postpartum hemorrhage management. So you can imagine if, term uterus has a blood flow of 1 liter per minute and your total cardiac output is 5 liters. So if a postpartum hemorrhage is happening, you have a very narrow window to resuscitate your patient and make sure you can stabilize and control the blood loss. So that's why we are so concerned about uterine tone after delivery and hemorrhage in the immediate postpartum period. Okay, and we'll talk more about it in a few minutes. So I just want to move on to pulmonary system. Like I mentioned, being an anesthesiologist, cardiology and pulmonology are, most important systems of interest. So similar to our cardiovascular system, there are multiple changes in the pulmonary system as well during pregnancy. And then these changes happen because of two reasons. One is the anatomic component because of the increasing gravid uterus, and the other is more hormonal due to, and we'll talk about it because of progesterone. So as gravid uterus is increasing in size, it starts moving cephalad, right? So what happens is the diaphragmatic displacement is happening and the contents are kind of moving upwards. Up to 4 centimeter of diaphragmatic displacement has been observed in the gravid patient. And, as a result of this, you actually see these on radiographic measurements as well. So you see the vertical chest cavity has decreased on an average of 4 centimeter, and then thoracic cage, while accommodating this movement, there is a slight increase in the anterior posterior diameter of the chest. So overall, the circumference of the chest slightly increases. And then also because now diaphragm is moving up, it can contribute to shortness of breath, and we'll talk about it in a second as well. So overall airway resistance is actually decreased due to dilation of large conducting bronchioles, secondary to elevated progesterone levels. So, like I mentioned earlier, one is an anatomic component, and the other is because of progesterone. Smaller airways are usually not affected in pregnancy. Another very important thing to remember is like capillary engorgement occur throughout the tracheal bronchial trees due to elevated volume and increased cardiac output. And again, as an anesthesiologist, this is very important for us because, it can contribute to airway trauma, difficult intubation, and bleeding while we are trying to place a breathing tube in a gravid patient. At the same time, there are several changes that occur with lung volumes and capacity as well. So total lung capacity is slightly decreased towards the term. Again, as an anesthesiologist, very important thing to remember is FRC is decreased, secondary to decrease in both expiratory reserve volume and residual volume. And at term, this decrease in FRC is kind of close to 15% from pre-pregnancy level. Again, very important because our patients will desaturate pretty quickly because of that. The tidal volume increases throughout pregnancy, initially due to decrease in inspiratory reserve volume and later due to decrease in FRC. At term, the tidal volume are usually 45% higher, but the interesting thing is there is no change in vital capacity, and then it does not change FEV1, FVC, or closing capacity as well. Um, Again, a dead space does not affect significantly during pregnancy. Anatomic dead space increases due to dilation of large airways, but alveolar dead space slightly decreases due to improved perfusion of previously underperfused alveolar units because of increased cardiac output. But I think most important thing to remember from this slide is that FRC is going to be decreased. And like I mentioned earlier, as an anesthesiologist, it's very important for us. Again, and for this clinical pearl, just a small statement. Why do pregnant patients desaturate more quickly during apnea? Decreased tidal volume, increased oxygen consumption and decreased FRC, increased dead space ventilation, reduce hemoglobin concentration. So this is basically because of decreased FRC and increased oxygen consumption. And we'll talk about oxygen consumption in a minute too. Again, talking about oxygen consumption. So I'm just going to move on to ventilatory changes. So increase in minute ventilation happens up to 45% at term. And it is because of both respiratory rate and tidal volume. Tidal volume is actually the main contributor. Respiratory rate increases slightly in the start. At term, minute ventilation is increased by 45%. And then once the labor start happening, this minute ventilation can increase dramatically up to 300%. Oxygen consumption increases during pregnancy by 20 to 40%, understandably, because you have a fetus now demanding oxygen all the time. There is higher metabolic demand. The placenta is growing, uterus is growing, fetus is growing, and additionally, fetal hemoglobin is highly efficient at extracting oxygen from maternal hemoglobin. So oxygen consumption increases because of multiple changes. And then during the second stage of labor, the oxygen consumption increases to 75%. So very important to remember. And talking about the ABGs, because of increased minute ventilation, the normal arterial blood gas in a pregnant patient is different from general population. Again, very important to remember to if you are in the middle of some emergency and you are trying to make a diagnosis. Pregnant patients are always slightly alkalotic, and PaCO2 is decreased in them, usually 30 to 32 millimeters of mercury. PA2 might be elevated again because of increased oxygen consumption and hyperventilation. and bicarbonate decreases to compensate for the decrease in PaCO2. So this is kind of a set of normal ABG in a pregnant patient. You can see pH 7.4, PaCO2 normal, like we talked about, 32, and then bicarb is dropped to compensate for this decrease in CO2. Moving on to GI system, again, very important for us as anesthesiologists. Multiple anatomic changes are happening. And again, like I mentioned, every physiological change in pregnancy happens at two levels, anatomic and hormonal. So again, because of the increasing size of the uterus, the stomach is elevated in your abdomen. There is loss of lower esophageal sphincter tone, and the intragastric pressure is increased as well. At the same time, there are changes in gastric emptying as well, again, during pregnancy and labor. Um, so what happens is, as gravid uterus moves out of the pelvis, the stomach is displaced cephalad. This movement leads to increased gastric pressure as well as change in the relationship with the diaphragm and the lower esophageal sphincter. Like you can see here, the gravid uterus increasing in size and pushing your stomach upwards towards the thorax. This contributes to overall decreased lower esophageal tone, and another main cause of lower esophageal tone is the increasing progesterone as well. During pregnancy, there is mixed vision that gastric emptying changes or not changes, but once the labor start, the gastric motility is definitely delayed. And there are multiple contributing factors. It could be because of sympathetic overactivity due to pain, due to catecholamines, and then sometimes, in labor, trying to provide analgesia, we are giving them systemic opioids, and then patients are on prolonged bed rest, which can contribute to it as well. Again, while we do epidural boluses with NARCs, it can contribute to gastric emptying, but again, it's a low dose. So but no matter what, you should always consider all the pregnant patients as full stomach. Again, because of all the reasons, lower esophageal tone is reduced. Like we talked about, the gastric emptying is slow and the intragastric pressure is high. So all of them, even if you are doing a neuraxial anesthesia, they need aspiration prophylaxis with any non-particulate antacids. And then maybe you all know that we do rapid sequence inductions and intubations in these patients. They need to have a definitive airway for sure. Okay. Just another clinical pearl that if you are doing liver testing in a pregnant patient, which level you will see mostly elevated. So placenta actually increases the production of alkaline phosphatase. So on LFTs, you see higher level of alkaline phosphatase in pregnant women. Okay, moving on to renal physiology, another very important system in pregnancy because it contributes to preeclampsia, and then creatinine clearance is very important. Um, as I briefly mentioned previously, that during pregnancy, the renal blood flow increases up to 60%. Because of that, it increases your GFR rate, and this leads to increased creatinine clearance. And then as a result of that, you have a decreased serum creatinine. So very important to know that normal creatinine at term is zero point 0.5 to zero point 0.6, and then abnormal more than one. And again, it's very important from preeclampsia diagnosis purposes. And it is pathological if it is more than 1%. Kidneys also anatomically may enlarge during pregnancy. Some studies have quoted up to 30% above pre-pregnancy level, and this is due to increased sodium retention and increased renin and aldosterone changes as well. So very important to know creatinine level, what's the normal one in pregnant patients. Another very important system, hematological system. Again, you all might have heard this, the pregnancy is a hypercoagulable state. What that means is that majority of clotting factors are increased in pregnancy. For us, again, from patient management purpose, the most important thing to remember is fibrinogen. So fibrinogen is one of the most important factors for pregnant women, and levels often approach twice the normal level of non-pregnant population. Very important to remember, especially in bleeding emergencies. For example, in our normal patient population, the normal fibrinogen level is like between 150 to 350. But in our obstetric population, the normal fibrinogen level is 350 to 650. So if you are in a bleeding emergency and then if the levels are closer to 200, or and you are anticipating the bleeding is ongoing, the level might drop further. You should work on transfusion of either cryoprecipitate, or if you have fibrinogen concentrate, something to pay attention to pretty quickly, because if you do not resuscitate and you do not keep the fibrinogen level more than 200, it can contribute to DIC. So the patient becomes at a very high risk of DIC. And especially at the time of delivery, when the placental separation is happening, there is a widespread activation of clotting cascade, and that is an increased risk of thromboembolic complication. We all have heard about amniotic fluid embolism, and all that happen immediately post delivery as well. I'm not sure what you guys do for thromboprophylaxis in pregnant patients. Our standard of practice is that we do compression devices during C-sections or prolonged bed rest, and any patient who has higher risk factor for hypercoagulability, or so we kind of do heparin or Livonox, or more anticoagulation management as well. Another thing to remember is there is increased platelet turnover in pregnancy, but overall the concentration stays normal, except some cases in gestational thrombocytopenia where we see the levels are dropping, and then sometimes lab results in pregnant patients may reveal a mild decrease in PT, INR, or PTT, but not too clinically significant. So most important thing to remember, fibrinogen, fibrinogen, fibrinogen. Resuscitating postpartum hemorrhage in a pregnant patient, focusing on fibrinogen, giving cryoprecipitate, or fibrinogen concentrate, whatever you guys have available in your practice. Okay, another important system is immunological, and we'll talk about it. And I just have a few more minutes to go. I know I don't want anyone to sleep. So, in pregnancy, we see elevated white blood cell count, but then the white cell blood function is reduced. Immune system increases production of white cells, and this peaks in third trimester. This is because of the elevated levels of cortisol and estrogen, but there is decreased functionality of these cells as well. Of course, this makes sense, right? Because we want to prevent attack on the fetus by the host. So basically, pregnancy is kind of considered as an immunocompromised state, because you want to prevent the host attack on fetus, but then it puts mom at a higher risk of infection and complications, and you might see more cases of sepsis during labor. You can see that, but another good side is patient with autoimmune diseases, they kind of see more, they are in remission during pregnancy as well. Something to remember. Just a clinical pearl, if you see a pregnant patient in labor has a white count of 18,000 without fever or symptoms, what's the best interpretation? Chorioamnionitis, physiological leukocytosis, acute infection requiring antibiotics, hematological malignancy. So it is actually the physiological leukocytosis that we are talking about. Okay, so pretty much towards the end, so just stay with me. A few more slides. Neurological system, very
Yeah,
important
yeah,
again.
don't worry.
I don't want people to sleep. So, Zoom is very non-interactive. So again, as an anesthesiologist, neurological system is very important. So, as pregnancy progresses, the sympathetic nervous system is upregulated and is the prominent and predominant autonomic system. There are many, again, anatomic changes that are occurring at the same time. Again, from anesthesiology perspective, the volume of epidural space decreases because the epidural venous plexus distends because of increased blood volume and increase intra-abdominal pressure as well. And also in many pregnant patients, the epidural fat deposition also increases. So this increase in contents of epidural space, it causes compression of thecal sac. And because of that, there is decreased CSF volume and potentially rapid spread cephalid of injected medication, cephalid spread of injected medication. So very important to know. Another thing to remember is that vertebral column kind of changes during pregnancy. There is this normal lumbar lordosis, and it is more exaggerated during pregnancy. The lumbar spinous processes also become rotated as well, again towards cephalid. And as a result of that, when we are doing epidural procedure, we'll have to have a steeper angulation as well. And then again, progesterone and the anatomical changes both contribute to this lordosis as well. Progesterone also contributes to laxity of ligaments throughout the musculoskeletal system. So, especially in pelvis, because, which makes sense physiologically because body wants to prepare the pelvis for delivery of fetus. So ligament stretch can lead to joint pain in patients, and you might have seen patients with sacroiliac joint pain, which can be, misdiagnosed as sciatica as well sometime. So very important to remember. And this pain can actually radiate towards posterior leg and, you know, yeah. So how it affects us, especially so I'm going to talk about more both from general anesthesia perspective and neuraxial anesthesia perspective. From neuraxial anesthesia perspective, as you know, we just talked about the changes in the epidural space and spinal space. So there is a risk of high block, high spinal block, high neuraxial block, or total spinal in these patients. So it is very important to be very cautious when we are doing neuraxial anesthesia in these patients or redosing our epidural volumes as well. Especially, sometimes we see a total spinal in patients who have running epidurals, and you do repeat spinal or another neuraxial procedure on these patients. So very important to remember they are at very high risk of high spinal block. So immediate availability of vasopressors and, your resuscitative equipment is very, very important whenever you are performing any kind of neuraxial procedure. Okay, talking about general anesthesia. So because of all the airway changes and reduced FRC that we just talked about, um, uh, starting from positioning and be very careful about positioning is very important. We should try to have a ramp because it helps not only optimizing the FRC for us, but it also helps us, to have patient in a better position, to better place laryngoscope and have adequate positioning because for intubation. Again, these patients have breast engorgement as well, and they can impede airway access as well. So positioning again become very important. Same for neuraxial anesthetic as well. Positioning is complicated by the gravid uterus, and patients are usually unable to flex their lumbar spine. And then we talked about left uterine displacement, any pregnant patient to prevent aortocaval compression. We talked about that for regional anesthesia, but it is very important for general anesthesia as well because your induction is going to cause hypotension. So you want to avoid that maternal fetal compromise. So that 15 to 20-degree tilt is important for general anesthesia as well, and it should be maintained. Another thing to remember is MAC requirement. So usually MAC requirements are decreased up to 30%. Some studies say up to 20% from non-pregnant state. And this is again because of elevated levels of progesterone and endorphins. So progesterone is kind of like a, relaxing hormone, sedating hormone. It depresses CNS. So it reduces your MAC significantly in pregnant patient as well. Similarly, the IV induction agents, there is higher sensitivity to them as well. So it's important to carefully titrate our dose. Also, pregnant women are more sensitive to local anesthetics, again, due to progesterone and endorphins. In most cases, the dose of local anesthetic given for neuraxial anesthesia or peripheral nerve block, is usually unchanged, but it's very important to be careful, especially from intravascular injection perspective. If you are doing an epidural, like we talked about, that they have engorged epidural vein plexus in the epidural space. So very important to remember. Okay. Again, talking about vasopressors, they are less sensitive to vasopressors such as phenylephrine and ephedrine, and usually needs higher dose as compared to non-pregnant patients. And we don't know yet why. Maybe because of higher baseline sympathetic activity. Although plasma cholinesterase production is decreased by approximately 25% in pregnancy, so you have to be careful. You should use the normal intubating dose of Sux, but something to keep in mind. They're also more sensitive to non-depolarizing muscle relaxants like rocuronium and stuff. So if you are using any long-term neuromuscular blocking agent, it's important to do nerve monitoring and twitch monitoring. Um, Again, they have lower serum concentration of albumin and other proteins, and there is increased proportion of free drug in the system as well. Okay, so again, we have been stressing the importance of increased risk in pregnant patient for airway and ventilation. They are at higher risk of difficult airway. Some studies quote up to 8 times higher. In older literature, it was considered closer to 400 times higher. So yeah, and all of this happens because of the changes that we just talked about: increased vascularity, airway edema, uh, and then we talked about the reduced FRC. Again, ventilation could be difficult because of the pharyngeal tissue and upper airway changes. Important to remember. We talked about how oxygenation can be impacted by decreased FRC, and then at the same time, they have increased oxygen consumption as well. So you will see that they desaturate pretty quickly, no matter how much pre-oxygenate you do these patients. So there is a tendency for them to deoxygenate pretty quickly after induction. Again, intubation is challenging because of higher vascularity, enlarged breast, edema. Again, some studies mention that Mallampati score can increase by as much as 2 classes over the course of labor. So, airway should always be re examined in a patient in labor. Not only pregnant. So we usually see all our patients once they are on the floor and admitted, and then, of course, before providing any kind of anesthesia. Regarding NPO guidelines, we talked about that these patients are high risk for aspiration. And so we should be very careful. All of these patients, they are considered full stomach after 20 weeks of pregnancy, and we do rapid sequence inductions in all of these patients if we have to do general anesthesia. All of these patients require aspiration prophylaxis. And then if it's an elective procedure, the standard ASA guidelines should be followed. So they are unchanged for pregnant patients. So if it's an elective procedure, we should follow ASA guidelines. But if it's an urgent and emergent situation, then of course we have to proceed with RSI. And always try our best to have a definitive airway in place. Sedation is, kind of risky in these patients.